psychedelic in this is not that with in my medical practice since 2022. And how do I share the screen? There's an issue about sharing the screen.
There is a button with arrow, should be, and then you have to press it, and then it will send the request.
Perfect. So I'm also the head. Yes, you're seeing. I'm also the executive secretary of one of the Swiss psychedelic medical association, and I'll give you some practical aspects about pharmacology and also group therapy that I collected over the last 3 years. Okay, so one of the big questions about psychedelic is how to dose patients, how much of one substance should I give to the patient? There are in psychedelic 3 different aspects for a session. The substance, which we will talk a bit later, so I won't spoil anything for now. I just want to share with you a link that Professor Lichti in Basel gave us in Switzerland, and that is accessible to everyone in the world about pharmacological interaction between psychedelics and classical medical treatment, so you don't put your patient at risk. I'll share the presentation. The link is clickable, so everyone will have access to that information. Second, the set, which is how the patient presents himself during the session. It's very important because sometimes we think that patient with a substance abuse history need stronger dosage because they messed up their brain cells, etc. It's not that true in the end. Substance abuse patient tends to have a tendency to dissociate, which means that if you gave them too strong dose, they will dissociate themselves and not have a full experience. So what I strongly advised is also because the first psychedelic session is a practical test for the patient about the psychedelic therapy setting, but also for the therapist about the patient, you should start very slow. There's a lot of apprehension when a patient that is naive for psychedelic starts psychedelic therapy. Start low, increase slowly. It allows a way better effects for the psychedelic therapy. Then the setting is very important because it will have an impact on how much you give to a patient. If it's a group versus a solo session, obviously in a solo session, the patient is much more confident, so it can go, it can really and benefit from a strong dose effect, whereas in group session, you also have to start slow because of every other person in the room that can distract and also refrain the patient from benefiting a full effect. Does the patient have previous experience with psychedelics? Obviously, having a previous experience with a substance make it easier to identify the effect, to let oneself go with the effect. So that has to be taken into account. And also, if you want to wander into strong dose of psychedelics let's take LSD, 400 micrograms or higher, it should start from an explicit will from the patient to explore those aspects. Otherwise, it can be very difficult for traumatized patient to put boundaries, and it can lead to very difficult experiences. So that also leads to the paradox: how could you explain the unpredictable effects of high dose to someone that basically does not? It's the discussion with the patient has really to be very precise about what you expect if you increase the dose. Okay, so I'll first start with ketamine. Don't mind the figure for now. This is one of the psychedelic I use mainly. I have one session a week, at least with patient in ketamine. I won't go over the pharmacology of it because it's an NMDA antagonist. I'm more going to go over the clinical aspect of it. It's very interesting for me because in Switzerland it's not illegal. It's a like classical prescription. I use sublingual pills, which I will explain why. The ideal dose for the first session, I think, is 150 milligrams, which roughly correspond to 50 milligrams IV or intramuscular. But I prefer the sublingual form for many aspects. There's no medical procedure in my practice. I don't have to put to use a syringe, or there's no infectious risk. And as you can see on the figure on the right, when you do oral or sublingual administration, the onset is way gentler. So there's really three phase, whereas when you do IV or IM, there's two phase. You're dosed and you come down. With the sublingual, you can have an onset, a plateau, and then a come down, and it's easier for the patient to be comfortable with the deploying effects of the ketamine. There are also disadvantages of sublingual formulas. One, you have to basically produce it. It's basic chemical manipulation. You use classic IV ketamine and you put that in form of pill, but still you need a small basic pharmacology lab. And then sublingual form is interesting because there's no first hepatic effect of the ketamine, which is quite sensible to the hepatic degradation, but it's dependent on the patient not swallowing his own saliva. So there's a lot of variation depending on the patient and his ability to follow instructions. Okay, so what is also very interesting with ketamine is that contrary to other psychedelics, there's no interaction between the classical psychiatric medication, antidepressants, anxiolytic, and neuroleptics, because it does not act on the same pathway. The only psychiatric medication it interacts with is lamotrigine, which decrease the effects. So this is something to pay attention of. Otherwise, there's really a lot of room to use ketamine with patients that have psychiatric medication. So you don't need to adjust those, and there's no modification of prescription, like I just said. The effect of ketamine has been a subject of debate. Is it a dissociative? Is it dreamy-like? I mean, there's some literature about it, but it mostly is interesting in how you can describe the effect of ketamine when a patient has not yet taken it, which is important because you will kind of prime the experience for him. You will narrow the possibilities. So how you present the effect of ketamine is quite important. Okay. So ketamine has also a very interesting aspect, which is that the effects are dose dependent. You can use both high dose ketamine and low dose ketamine, and you have very different effects between the two types of dosing. At low doses, it has a more psycholytic aspect, which means the patient is very able to communicate with the therapist. And you can work on the body ownership if you integrate movement in your therapy, or you can use a kind of empathogenic effect, quite MDMA-like, which is very interesting when you have to build a trust and work with about the attachment aspects for patients. When you do high dose, you go to a psychedelic territory with a more dissociative effect. You can have some memories that start to be relieved again, which can be quite strong and difficult for patients. And you can have at the upper doses this ego dissolution known as K-hole when it's used recreatively. On the the table has like a kind of equivalence for the effects and the dosage. I find interesting because it helps narrow the targets you want to achieve. Okay, so now I'll describe how my setting is in my clinical practice. So what is very interesting is I can do the preparation, the session, and the integration in the same room. So there's some art on the wall, there's some, and the patient is very familiar in the space that the session is taking place. So if he feels disoriented, there are visual cues that help him ground himself and know, okay, it's okay, I'm very high, but I'm in this office. I've been so many times, so everything is okay. I think that's very important, and visual cues for the session are very grounding for the patient. Since I use a sublingual form, I ask the patient to be seated at the beginning of the experience and let the pill melt under his tongue. This is just practical because it helps lower the saliva produced, and you don't end up with a liter or so of saliva. It's way more comfortable, and it also helps the patient work with a small exercise before the ketamine takes effect, which is how do I support discomfort? How do I manage discomfort that I self-impose? And at which point do I consider, okay, my discomfort is way enough. I don't have to follow a rule that is asked from someone else, the practitioner. So already there's some very interesting aspects about how the patient feel and approach the onset of the ketamine. So this is just what I saw. And also, if you decrease the saliva produced, you increase the chance of not swallowing the saliva. So you increase the effect of the ketamine that is more absorbed. So this is something that is interesting. And roughly after 30 minutes, the onset of the ketamine begins. At that point, 99% of the patients have decided to lie down. Only some perfectionists try to sit for the whole experience. Okay, so what is also very interesting with ketamine is that since it's a dissociative psychedelic, obviously if you reassociate yourself by moving, by opening your eyes, by speaking, by touching yourself, you decrease the effect. So you can explain that to the patient and have them known and be reassured by the fact that they can manage the depth of the effect, which is very, very, very securing for them. So to maximize the dissociation, I advise the patients to lie down and try to be as still as they can. And this, like doing diving, they will dive deeper. And if they want, they can, get closer to the surface, then dive deeper again. The ability to control is very, very securing. So I have this is anecdotal. This is how I dose the patients. So 60 milligrams sublingual, then 10 minutes after 60 milligrams sublingual again. Then when the onset kicks in, the option to have 15 milligrams booster, depending on how they feel. If you remember the last slide, a stronger ketamine experience does not mean it's a better ketamine experience. It's way more abstract, which can be or not interesting. But if patients want to explore memories or autobiographical emotions, they should be advised to have a lower dosage instead of a high dosage. The whole experience lasts for 2 hours, which is very also manageable in a clinical practice. And one of the aspects I discovered with experience is that the metabolite of ketamine, which I forgot the name, is very irritating for the bladder tissue, which means that it gave the patients the sensation that they need to go to the toilet to urinate. So I strongly advise the patient not to drink water at least 4 hours before the experience, And just before taking the pills, they have to go to the toilet to really make sure that the bladder is empty so they can be very comfortable and know that even if they feel like they need to go to the toilet, it's only, sensory stimulation. They won't pee over themselves and everything is fine. Okay, and what is very also interesting with ketamine, one of the difficulty, of ketamine is that there's a calm down after 2 hours, and the patient will have a greater ability to recollect what has happened during the session. And this ability to recollect will decrease with time. This is the dreamy-like aspect of ketamine. It's like, when you wake up after a very vivid dream, you have many details that you can remember. If you wait 1 hour, the detail begins to fade. So this is why ketamine has, sorry, I skipped too fast. This is why ketamine needs better work from the therapist. The therapist during the pre-integration has to be very moving. What I also do is I record the patient if they agree, so they can listen to the recording after a while when they forget. Okay, so now I'll just briefly talk about the 3 other psychedelic I can use in Switzerland with authorization from the government, because maybe one day you'll be able to use them also in your practices. MDMA is very interesting for the PTSD aspect. It acts with the liberation of neurotransmitters. It works over every big neurotransmitters: serotonin, noradrenaline, norepinephrine, and dopamine. This is why the dopamine makes people want to take more MDMA when the calm down begin to start. The ideal dosing is depending on the weight of the patient. So roughly, if the patient is over 65 kilo, you have to make him take 155 milligrams. Going to dosage over 125 milligrams has not proved any form of increased efficacy. On the opposite, you increase the neurotoxicity that happens when you take too much MDMA in one session, or when you repeat, try to prolong the session with boosters, or if you repeat the session over a too short period of time, between a week and a month, it starts to get neurotoxic over the serotonin pathways, which is obviously not something you want for your patients. Okay, about the pharmacokinetics and pharmacodynamics, there's some interest because MDMA works with serotonin, which is also the target of many psychiatric medications. The main antidepressant class, which is SSRI, really decreased the effect. It almost divide them by 3. I would not advise to increase the dose by 3 in response. I would instead advise to try to switch to non-SSRI antidepressant like the bupropion or myoserine, which does help a lot and does not decrease the effect of the MDMA. It's metabolized into the liver with the cytochrome 2D6. So you have to be aware of interaction with other treatments, other medical treatment that can inhibit this metabolic pathway. And also beware of the narrow therapeutic index. 125 milligrams is a standard dose. Do not try to go higher. Otherwise, you start to get toxic, and this is not what you want. Do be aware for patients with history, for example, of breast cancer or other treatment that are very sensitive to pharmacokinetic variation to the cytochrome 2D6, that after an MDMA session, the patient becomes a slow metabolizer for 3 weeks. So if there are vital medications that are sensible, do discuss with the other doctors how to adjust the dose, or if the MDMA session has to happen now, or should it wait for example, cancer treatment to be over. Okay, MDMA has been famously known for the heavy calm down it comes with, the Blue Monday effect. There's a debate about the reality. Blue Monday is how people, not the day after, but the second day after the session, experience depressive symptoms because of the serotonin depletion. There's really a strong debate in the scientific community. Some authors think that it's linked to how it is used in recreative setting, which means high dose with physical exertion through dance, with alcohol consumed, with tobacco, with other drugs, with lack of sleep, etc. I do think that for the dose we use in therapy, it's not that much an effect. Some people are more sensitive. I'd say about 20% experience a bit of decrease. It's also difficult to know if it's linked to the traumatic memories that can arise throughout the session or just to the pharmacological effects. So yeah, keep that in mind, but it's not something that is very menacing for the patient. If you space the session also, as I talked, the repetition of MDMA session can be neurotoxic. Space your session with 2 or 3 months intervals. And you can also, this is not something that has been published, it's more something that comes from the underground use and recreative use of MDMA. But if you give antioxidants to your patients, with the vitamin C, for example, if you give tryptophan, which is a precursor of serotonin, and also if you do inform your patient, remind your patient throughout the session to drink water. MDMA increase the heart rate, increase the muscle contraction, so it can cause dehydration. So if you try to be preventive on all those 3 aspects, oxidation, serotonin depletion, and dehydration, you really dampen the risk of Blue Monday. And also, if you have the idea, there's no interest in microdosing MDMA. There are some people that have tried to, and yeah, there's no pharmacological interest to it. Okay, LSD 25, the gift of Switzerland to the world. So it acts on the serotonin pathway, but also a bit on the dopamine pathway, which is why people experience trouble sleeping after an LSD session, which is also why LSD has been researched for ADHD medication in microdosing. The ideal dosage for the session depends on the form of LSD you can get. Here in Switzerland, we can have LSD base, which is 100 micrograms. In the 60s and in the underground use, you have LSD tartrate, which is easier to synthesize, and there's a small equivalence to make. Especially if you study the old article from the 60s, do make the conversion because they gave higher doses, but still it's important to put that back. Okay, so as antidepressant, especially SSRI works on the serotonin pathway, there's a decrease of the effect for patients that have that benefit from SSRI. So you should be able that they will experience less intense subjective effect, but the therapeutic effect, there's a debate if it's the same or not. I do think that psychedelics are used in psychotherapy, so if the subjective effect is less intense, the therapeutic effect will be a bit less intense. So if you can stop the antidepressant at least 5 half-life before the session, it's good. If you can't, it's okay. But if you can't, do not increase the dosage too fast because it can really become unpredictable into the effects. Some antidepressants can also be antagonists for the same receptor that LSD is agonist. So there are, for example, 2 antidepressants, fluoxetine, Prozac, and also trazodone. I don't know if you have those in the trazodone in Ukraine, but those are really strong antagonists, and people under fluoxetine will have no subjective effects almost under LSD or psilocybin. So be aware of that. The repetition of session has to be spaced because after LSD session, patients are desensitized on the receptor, serotonin receptor. So at least wait at least a week before starting a new session. If you do a session throughout several doses, like you can do in ketamine, it won't work, or you have to double the dose every time, which is, again, non-predictable, so a bit dangerous. Okay. One of the main interests for me of LSD in psychotherapy is that it's very long, between 10 to 12 hours. So the interest is sometimes for patients with strong defense mechanism that did not benefit from shorter psychedelic like psilocybin. The length of the 10, 12 hours makes it easier to go through those defense mechanisms. Yeah, it's also very tiring for the therapist. To stop the effect of a serotonergic psychedelic, as I said, you can use the trazodone, which is this antidepressant with a strong antagonism of serotonin receptors. You can also use neuroleptic or ketanserin, which is kind of a neuroleptic. For the neuroleptic, I would advise ketamine or olanzapine to have this anxiolytic and sedative effect. Also, if you need, you can give benzodiazepine to patient. It helps with the anxiety. It does not help with the length of, it does help a bit with the length of the trip, but not that much. Also, be aware that because of the length of the experience, if patients experience negative effects in the second half of the experience, do remind them to eat something. It's been 6 to 8 hours, they did not need anything, and they can experience just a basic hypoglycemia. Okay, with LSD, you can obviously microdose, which is also a form that is interesting for ADHD, but also for a small form of depression or even premenstrual syndrome. This is just clinical insight. There's a very low academic evidence for that, but sometimes I advise patients to use like that. For the microdosing, you should be aware of the risk of cardiac valvulopathy, which is linked to an activation of the serotonin pathway in the heart valves. And the efficacy is not that clear, but still whatever works if you can. Okay, psilocybin then. So in Switzerland, I work with synthetic psilocybin, which is not harvested from mushroom. It's sometimes a disappointment for patients that want to experience a natural psychedelic. And it deprives us from the witch's brew effect, because in the psilocybe mushroom there are many other active psychoactive alkaloids, which we have not if we only have a pure form of psilocybin. So maybe this will change in some way. The ideal dosage for first session on synthetic psilocybin is 20 milligrams to have a rough equivalent. 1 gram of dried psilocybe cubensis is equivalent to 6 milligrams of psilocybin. And to have an equivalence with LSD, roughly it's 20 milligrams of psilocybin is equivalent to 100 microgram of LSD base, of course. The pharmacokinetic and pharmacodynamic aspects are the same as with LSD. And psilocybin is just shorter, but what I just said about the antidepressant, they can cut the effect, about the desensitization, about the effect of the SSRI dampening the effect, it all applies kind of the same to psilocybin. And the difference between LSD and psilocybin is also a matter of debate. Here in Switzerland, we have this Professor Lichty, which is a pharmacologist, who says that psilocybin has no subjective difference with LSD. This is an opinion, and other academic anthropologic researcher that study underground use wants to say otherwise. So I'll let you make your own opinion on that subject. Okay. what is very strange and for now has no explanation for me is that psilocybin has a greater risk of heart valvulopathy. So you should be way more aware of this if you microdose with psilocybin. Okay, and now maybe to an aspect that also is not about pure pharmacology, but still is a bit. It's about how to implement the use of psychedelics in group therapy. I've been having a group of psychedelic-assisted therapy now for over a year, and I'm trying with a mixed group between MDMA and LSD. And we are also working on a project about a ketamine group that should involve active dance, which is going to be quite interesting. Okay, so if you want to create a group of psychedelic-assisted therapy, you have to reflect and think about the base parameters of your group, because every parameters that is planned and explained before is a secure boundary for the patients. And since they will experience at the same time the group effect and the substance effect, they have to feel very secure about the boundaries and the rules of those space. You have to think about the size, and the size is really about how many therapists and patients do you have. Here in Switzerland, we have the luxury of having one therapist for every 3 to 4 patients. Be aware that, yeah, if one patient is in difficulty, it takes one therapist. If one therapist has to go to the toilet at the same times, it leaves even the third therapist with about 6, 8 patients, and it can be very rough for the therapist to manage. Group psychedelic therapy is very tiring, and at the end of the day, you're really happy that the day has ended. You have to think about the open versus closed aspect of the group, which means either you have a group that patients can join, do their works, get better, and at some point leave, with new patients coming and the whole group renewing itself over the time. Or you can have a closed group, meaning you start with a precise date, you define a precise number of sessions, and you know that no new participant will join the group. Every both aspects have their pros and cons. It's really like in group therapy, in classical group therapy. You have also to determine whether or not you want to have a fixed substance, if you want to have patient with only one substance, if patient can change the substance. For example, the group we have MDMA and psilocybin, which have the same length, but is obviously not the same effect. So this is also very interesting, but this has to be decided before the group start and not on the go, because otherwise patients will feel less secure and will be a bit mixed in how they navigate the group. You also have to determine the frequency of the session, notably the dosing session, and also the frequency of the preparation and integration session before and after the dosing session. What I also would advise is that group psychedelic assisted therapy is group therapy. So you also should have proper group session meanwhile to build the group dynamics. It does help a lot. So first start how to know which patient you can have. Just start to screen new patient you have either in your individual session, or do be aware that for a patient to have his first psychedelic experience in a group is a bit less secure than having first individual session, then group session. So yeah, do be aware also of the confidentiality. Obviously, as in group therapy, you have to, as a therapist, really divide yourself between what you have been told into individual session, for example, sexual abuse of a patient, and what has been told into the group session. if the patient don't want to talk about his history of sexual abuse, you have to act like you are not aware of this aspect. And this is also a very tiring process when you have several patients with a difficult history. You have to really navigate between all those patient history and what has been said, what has not been said, etc. Okay, and obviously do not neglect the group therapy. Psychedelic are very interesting and potent molecules, but do not fall into the trap of psychedelic exceptionalism. Classic group therapy rules, books, advice, tips also apply in some form in psychedelic-assisted group therapy. Okay, how to prepare the group? This is very interesting. We did a first meeting with the possibility for the patient to just meet themselves in this closed group and have the possibility of backing out. We had 10 patients screened and 3 of them backed out just because of this first session. One realized that she was not available as she thought, and the other 2 realized that what they experienced in the group dynamic made them relieve some aspect, and they wanted first to work on that in the individual session. So the first pre-meeting session is quite important. One patient have to present himself during the session, so keep that very open. Obviously, the strict minimal is have a name or pseudonym for the patient, and then they can talk or not about the previous psychedelic experience. It's not mandatory, obviously. They can also talk or not about their intention when they join the group. Do respect if patients stay very silent or intimate about the reason that brings them. And obviously, there's no obligation to talk about the psychiatric condition. Some patients can stay very silent during groups. Do respect that. Do not have them, under the spotlight to talk about what they don't want to share with the group. There's some icebreaker to facilitate and build this group momentum that we use. For example, at the beginning of each presentation, preparation, and integration session, we form a circle, we stand up, and after a small moment of meditation, each member of the group, therapist and patient, present himself or herself with a gesture, for example, oh, and a word quoting how he or she feel today. And every member of the group at the same time repeats it 3 times. So for example, I can say, I'm feeling grateful, and every member is going to repeat grateful, grateful. It builds, it's a very bonding aspects. You can also use the preparation session to co-create the group sitting and have the group work, the patient work on how the dosing session is going to look. Do they want an altar? Do they want candle? Will everyone bring, for example, some flower, etc.? What's the music you're going to pass? Use the preparation session to have the patient already think and represent themselves what the dosing day is going to be. And obviously, having the patient discussing boundaries, the individual boundaries, and the rule and the roles of the dosing session does help. For example, if one patient is not comfortable with proximity, do discuss that in group. Do observe that maybe other people are comfortable, but do respect and have a rule that respects everyone needs. Also, there's an eye contact game that can be helpful if people meet for the first or the first few times. You get up in the room, everyone walks randomly, and then at some point, at some signal, someone clap in his hand, and you have to find another person that you look in the eye without speaking for 20 seconds, and then you debrief with that person how that made you feel both, and so you begin to bond. You can also practice for patients, especially patients that are naive to psychedelic, what is it to sit in silence, listening to music with other people and listening to the other people noises, respiration, cough, etc. It does sometimes helps the creation of rules that were not evident when asked explicitly. And then about the substances you can use, as I said, you can use short duration substances with the ketamine interesting because there's different dosage possible. You can have high psychedelic dose where everyone is lying down very still, or you can have low doses of ketamine and have people dance on the ketamine, which is very helpful, especially for people that have tendency to dissociate. It's very interesting. They discovered their own body again. So that's very, very useful. You can also have people interact verbally, talking to each other way more with low dosage, whereas high dosage are more static. You can also have longer duration psychedelic session, as I said. So the group I have is mixed with psilocybin FDMA with the same duration. Obviously, don't mix LSD with a shorter duration because at some point you will have sober patient and still under effect patient, which is difficult to manage, even though Peter Gasson in Switzerland did that with MDMA and LSD with interesting result. And also you can, yeah, if you have long session, beware of the fatigues of the patients and also of the therapist. It's very tiring, it's very demanding. So do have some breaks and be gentle of yourself about the number of session of group session you have. Once every week is already a lot. I should not advise to go higher if you can manage. And also keep the option for participant of the group to participate at the dosing sessions without taking any substances. It will keep the group dynamic dense, packed. And also, if you have an open group, you can have patients sometimes coming just to be with the group without dosing, just integrating. They can also observe what is happening to patient during the dosing. It's also for some a good way to slowly build the trust and allow themselves to take the substance. So yeah, it's very interesting to have group psychedelic assisted therapy with patient that does not take any psychedelic. So do not refrain, do not limit yourself. Okay, what is also very important for me, I work in a psychotherapeutic approach of psychedelic assisted therapy. So integration obviously is one of the biggest challenge and work as a therapist. So you have really to decide when you have the integration session, either right after. I would recommend to wait a few days to have each patient integrate in their own at their own pace and then have a sharing all together. You have also to decide how many integration session you want, with the knowing that the last integration session is going to be maybe the first preparation session. So there's really a continuum between the dosing session with the integration preparing the new session. There are also tools to facilitate integration. Some form, using the same room for preparation, dosing session, and integration helps a lot. Sometimes people remember, oh, okay, I was looking at that tree by the window or that picture on the wall, and it makes me remember what I experienced during the session. Having the same therapist present obviously is very important because being present during the dosing session makes you a witness of what has happened. So you can also put some reality back into what patient experimented under psychedelic substance, which is sometimes not real, but also you can witness what they've been through, and this is very helpful for patients. You can use for integration session the same icebreaker as we explained last slide. For example, the small gesture game is a really good way to start the group with a good energy, some humor, and people are really patients are really demanding for that when I forget and I go too fast to the integration. So yeah, if no one wants to take the lead and talk about his or her own experience, you can, as a therapist, start by just explicitly stating what you externally observed during the session. For example, some people were restless and a bit moving, or there was at some point a bird or external stimulation. This does help the patient to put themselves back in the memory of the session. Be aware of the time each one takes during this group session, because some people will uh, talk a lot about their own experience, although we stay silent. Do be aware of those silent person and offer them a space. Sometimes, as in group therapy, silent person have very interesting things to share that just feel too oppressed by talkative person and extroverted person to take that space. Do also allow people to stay silent if they just want to listen and integrate by themselves within themselves. Obviously, that's also a role. And there are a few card games available, but only in English. I put the link of both. The second one, the integration card game, is produced by the Belgium Psychedelic Therapy Association. They have a translation in French, in English, and in Dutch. But I think that yeah, if someone wants to work on the Ukrainian translation, they would be very interesting to contact. Okay, so this is the end of my presentation. I've cited many articles. You will have the bibliography at the end. I will send them to Inacrilo, which will follow it to you. But there are a few essential books that I would recommend as a psychedelic interested therapist. All of them are in English. You can find them if you know how to download some book on platforms. Illegal, you can download them from free. In Switzerland, it's not illegal unless I share them to you. So yeah, there are website where you can do those. So about pharmacology, sorry, it happens. It appears in a blog. The book of Andrew Gallimore, Reality Switch Technology, is very interesting because it starts with the necessity of having a high school biology knowledge, and it takes you step by step through the pharmacological and cognitive effects of psychedelics. So it's a very useful reading for people outside the neuroscience field. It's very easy to read if you can read in English. About ketamine therapy, I've read many, almost every book on the subject of ketamine. The one I found the best about the therapeutic, psychotherapeutic use of ketamine is the Ketamine Papers, which is edited by MAPS and curated by Phil Wilson, who is a very big name in the ketamine therapy in Northern America. It's very interesting. There are both psychotherapeutic chapters, pharmacological chapters, ethical, etc. So it's very interesting. And if you're interested in the sociological aspect of psychedelic, which is also a field of interest for me, there are two books that I would deem very interesting. It's by Andy Letcher, Shroom, which is a sociological history of psilocybin mushroom. But also, if you're interested into how the psychedelic researchers have their own untold and unavowed metaphysics, I would advise Nikolai Langlitz, Neuropsychedelia, which speak about the research of psychedelic during the last 10 years and the metaphysical aspect of the neuroscientists that worked on those subjects. Okay, so thank you for listening. I hope I was clear, not speaking too fast. Thank you for the translators that had to translate my poor English. And if you're okay, we can have questions, as many as you want.
Дуже дякую, Олександре, за таку цікаву змістовну лекцію. Дуже багато практичного матеріалу. Ми вже з нетерпінням хочемо вас запросити на інтервізійні групи, тому що ваша експертиза дуже цінна і стільки у вас різного досвіду з різними речовинами і вже досить довго. Я скористаюся можливістю задати перше питання. Будь ласка, хто вже готовий задавати питання, можете підняти ручку. Є тут таке сердечко, ви можете на нього клікнути і там підняти руку, якщо у вас є питання. Ми тоді по черзі будемо давати можливість вам його задавати. Можна також писати в чат, але я думаю, що краще з рукою, тоді у нас буде таке більш жива взаємодія. То питання від мене, я просто розумію, що ви психіатр і що ви мали можливість працювати з пацієнтами і без психоделіків, за допомогою інших медичних препаратів. Скажіть, ваша особиста думка, як змінилася ваша практика як психіатра, коли ви почали працювати з психоделіками? Чи ви бачите суттєву різницю в покращенні або в лікуванні саме людей таким чином? Тим паче ви використовуєте багато різних речовин. Чи це суттєво змінило вашу практику?
Yes, yes, obviously. What I found very interesting is the categorization of diagnosis, whereas coming from the neuroscience field, when I received patient, I have very fragmented view of their diagnostics and history, whereas psychedelic is an integrative practice. So the whole story makes more sense, especially since in the recent research, the psychedelic indication is treatment-resistant depression, but the treatment-resistant depression is a very unclear diagnosis entity. Sometimes it's just, another diagnosis. Sometimes it's depression, but with a history of PTSD that the patient does not allow themselves to talk to, or that the therapist can't even hear. So yeah, I had patients that came to me sent by other psychiatrists with a diagnosis of treatment-resistant depression. And when I ask about repeated trauma, for example, not the classical question you have, did you suffer from a precise traumatic event or anything? If you let some space to the patient, sometimes they tell you things, or they tell you things after a few sessions of psychedelics that they did not allow themselves to tell other therapists before. So the pace my pace has been very slower. Also because of the difficulty to mix psychedelics and classical treatments, I may not be as quick to prescribe antidepressants, but on the whole aspect, even for patients without psychedelic therapy, I'm not as fast to prescribe antidepressants anymore. But this is a big tendency in the psychiatric field, I think. If that's an answer for your question.
Так, дуже дякую. І ще одне уточнення. А саме інтеграцію в системі, підготовка, дозингова сесія, інтеграція, ви проводите всі ці етапи з одним пацієнтом? Чи це різні спеціалісти, які проводять інтеграцію, наприклад, після вашої роботи в дозинговій сесії? Чи ви ведете людей постійно від початку до завершення?
Both. I have some patients that I have in psychotherapy, so I do the integration session with them. I also have patients sent to me for just being a psychedelic operative. Um, what I observe is that just that does not work as well. You know, being not be the integration therapist, not being the therapist present during the session does not work as well. But do remember that the integration is a patient-centered process. Uh, Thinking about the day of the session under the shower is already integration. Having, if the patient have a conversation with a relative, his mom, his spouse, his children, a friend about the dosing session, it's already integration. Integration is every reflexive steps a patient have about the dosing session and what he wants to change in his life afterwards. So do not feel like integration is an exclusivity for the therapist. It's the patient that does it. And as an integration, as a therapist, you only facilitate the integration process.
Дуже дякую. Так, якщо є питання, будь ласка, піднімайте ручку, можете задавати. Так, Артем, будь ласка.
Так, я з питанням підключусь і поступово так в тебе цю модерацію перехвачу. По-перше, дякую дуже. Дуже цікаво, дуже практично. От, і в мене тут багато цікавості і такого збудження. От, я собі певні замітки зробив. Так. От. В мене таке питання практичне. Да? На що ви спираєтесь при виборі речовини? Є клієнт, є його історія, контекст та наратив, де він, та? І на що ви спираєтесь при виборі речовини, та? І одразу далі, на що ви спираєтесь при виборі дозування цієї речовини? Дякую.
Okay. So about how I choose substance, I don't work like the classical research, which is based on diagnosis. In Switzerland, you have to know that I can use ketamine almost freely, and for the other three substances, I have to write to the Ministry of Health, do a lot of administrative work to have those authorizations, so it's longer. So obviously, I first use ketamine because it's shorter, because the patient can navigate him or herself during the session, and also because it's very helpful to build the base of feeling secure again. It's a very good practical aspect for the patient to test the psychedelic setting we work into. What is it to be under influence of a substance with someone sober in the same space? Do I feel secure enough to let go and experience the full effect? So ketamine is always kind of a first step to have people discover what are non-ordinary conscious states. And sometimes it's already enough having them do a few ketamine sessions. Then, after a while, if it takes a bit more time to process, we can use either psilocybin and LSD, serotoninergic psychedelic, or MDMA, and it all depends on whether or not there are the way I see it is MDMA is more about being in contact with the other and being in contact with oneself on the emotional aspects. So it does help with PTSD. It does help also with a patient with autism. Whereas psilocybin and LSD work with rigid cognitive structure and paradigm. But you can have rigid cognitive aspects in PTSD. if patients are not able to contextualize themselves into life, for example, someone that has suffered from sexual abuse from a man can say, okay, every man is dangerous on that aspect. It's a default. It's a default of contextualization. It's not about relieving the trauma and being blocked on the emotional aspects. So you can also use psilocybin or LSD for some uh, aspects of PTSD. Uh, so yeah, this is how. And I about psilocybin versus LSD is really about also if sometimes patients get stuck in a loop and can't get out of that loop before the effects takes down because psilocybin is too short. You can go to LSD to have them help have this breakthrough, or yeah, the calm down being very long with LSD, the pre-integration session where you talk, you have this psycholytic approach, which is very interesting and efficient for psychotherapists, is very long. At the end of LSD session, you have like 4 hours of psychotherapy, almost classical with the patient. So it's a very interesting space to explore. Obviously, do LSD session with patient you feel comfortable with, because 10 hours with someone you can't bear, that someone you can't feel comfortable with, it can be very long.
Угу, дякую. А в роботі з ЛСД це 8-12 годин контакту терапевтичного з людиною. Ви працюєте зазвичай тет-а-тет чи в парі. От, як ви розподіляєте це навантаження? Бо це
Yeah.
дуже довго.
No, no, no. I forget to say that. For classical psychedelic, LSD, psilocybin, MDMA, I work with a co-therapist. I advise strongly, if you can, to do that. My co-therapist is a woman, a young psychologist, so we have both male and female aspects. She is a psychologist, so we have also those two aspects working. I come from neuroscience and cognitive aspects. She comes from yoga and psycho embodied therapy. So it's very complementary. If you can do that, especially because when you have to manage the patient going through a difficult time, when you have to manage the music, when you have to manage, everything, and you suddenly need to go to the toilet, it can be very complicated. So if you can work in pairs, it's really easier, even for individual sessions.
Угу. Так, дякую, бо справді дуже таки пролонгована робота і виснажлива в першу чергу для терапевта. От. Про це мало говорять зі сторони саме терапевта, багато говорять про клієнтський досвід і участь. От, хотів знати, що щось цікаво про різницю з псилоцибіном і ЛСД. Так, що псилоцибін за типом досвіду, з відгуків та збору такого емпіричного досвіду може бути більш таким суб'єктивним емоційним досвідом. Так? Той час, коли ЛСД, наче клієнт і людина в досвіді може направляти свою увагу і вибирати, куди направляється увага. Могли би поділитися своїми відчуттями стосовно цих речовин.
Okay, so it's very non-academic. I have a friend who's a psychedelic nerd who is also very much into plant-based medicine, who told me that LSD can bring him to some space that are the same spaces as the tobacco plant, which on a pharmacological aspect makes some sense because LSD has this dopaminergic aspect, but is also stimulant for the same receptors nicotine can stimulate. So yeah, it's way more grounded and can be very, sharp. So yeah, but this is also the way I represent myself. LSD works, so it has some influence on the patients with the psilocybin experiences, for example, being a more cognitive, from a more cognitive origin. Once I told patients they can experience the effects in their body, in bodily sensation, they experience more bodily sensations during the session. So how the therapist represents the effects has an impact on how the patients live the session. Secondly, the psilocybin is it's the molecular name is like 4-HO-DMT. So it's some author thinks it's an orally active form of DMT, dimethyltryptophan, which has not the same subjective effect as LSD. But yeah, there's a very strong debate between pharmacologists who says, okay, the main interest is stimulating that this kind of receptors, and they both stimulate it, so it's the same. And psychotherapists, naturalistic and spiritualistic users that say no, it's definitely not the same effect. So yeah, it's a debate. I personally think they are not the same, and yeah, it feels itself during the effect. Also, LSD has this specificity of making itself a crystal structure in the receptors. So the effects are way more linear because it does not move, dissociate, reassociate from the receptors, where psilocybin can be very much wavy in the effects you can experience. That's
Угу. Та, дякую. Пана Вадима піднята рука, будь ласка.
Хочу також подякувати Олександра за дуже цікавий матеріал та власний досвід і задати свої запитання. Скажіть, будь ласка, що ви можете сказати про можливість використання кетаміну для лікування біполярного афективного розладу? Та яка тут, з вашої точки зору, є вірна тактика? Наприклад, коли ми ще не почали активно використовувати фармакотерапію, в цьому випадку, що ми можемо очікувати від кетамінової терапії? І другий варіант, коли ми маємо випадок резистентності до фармакотерапії і вже достатньо високі дози, яким чином поєднувати ці методи? І який може бути курс у цьому випадку, і які можна очікувати довготривалі наслідки?
Okay, about the first question about bipolar disorder and ketamine use, there are some study about bipolar 2 being benefiting from ketamine therapy without any risk or major risk, but that's a very small study, any risk of bipolar relapse. What is interesting with ketamine, if your patient is not under lamotrigine treatment, is that you can have a ketamine treatment option with the mood regulator treatment. So you can work with that. I think during the summer there were a few studies that got out about bipolar type 1 ketamine efficacy. I can't remember. I just skipped the lecture, but there's some literature. It's interesting. Do start very low. Obviously, monitor your patient for every manic relapse. Keep the mood regulator on, and be very prudent. Being working in my own office under my own. It's totally outside validated treatment, even in Switzerland. So I don't try to risk too much with this type of patients. So that's about the first question. And the second question was about what happens if patients are psychedelic resistant. Is that right? Yeah. So yeah, that does happen sometimes. As I said in the first slide, sometimes is they don't feel much effects because or they feel very low effect because the dosage are too high and they just block themselves. I have a patient, for example, that because he has treatment, etc., had a 40 milligram psilocybin session, which is quite high. It's about 8 grams of dried mushrooms, so very high. And he had a shorter, very cognitive session. And when we divided the dosage by 2 and gave him 15 to 20 milligrams, he had longer session and way more emotionally intense sessions. So do you think, okay, maybe the dosage is too high for the patient to allow himself to work during the psychedelic process? What is also very interesting is how patient can feel frustrated. They prepared themselves for the dosing session, they came, they took the substance, and nothing happened. Okay, what happens when you have to sit with nothing? What happens when you get bored? How do you feel when nothing happens? And how do you feel when you sit with someone and nothing happens for a few hours? Then you have, having a dosing session without any subjective effects is already something very, very interesting. You have the a therapy session that can last a bit longer when you can, as a therapist, allow yourself to be way more silent or, yeah. So nothingness is also very interesting to explore during sessions, if that's an answer to your second part.
Дякую. Якщо дозволите ще одне запитання. Скажіть, будь ласка, з вашого досвіду, які препарати та схеми більш ефективні при лікуванні ПТСР? І які краще мати комбінації з фармакотерапією? Як поєднувати ці методи?
Okay, you can use ketamine quite effectively with PTSD to help the patient build his base of security back after a trauma. MDMA is very interesting, and yeah, for some patients with repeated trauma, sometimes using psilocybin, as I said, is also very important to make those rigidity flexible again. But yeah, there's no, I don't use any protocol like in the academic research. I have a lot of freedom. So it really depends on each patient. Sometimes patients have only one session of ketamine, then we go to other psychedelics. Sometimes they just have a session of ketamine that does help them to navigate to and get back to a classical psychotherapy again. What I observe is for patient after psychedelic session, you can start to decrease the treatment. Psychiatric treatment tend to decrease symptoms by making them disconnected from the patient. But the patient feel also disconnected from themselves, from their life. So the whole path of psychedelic therapies is make the way back to being connected again. So this is sometimes, even though patients can, stop the treatment, there's still some process going on, and you still follow them in psychotherapy. If that answers your question.
Так, дякую. І якщо можливо, ще одне уточнення. Яку ви обираєте тактику, коли бачите, що ефект недостатній від першої сесії? Ви підвищуєте дозу, і при яких обставинах ви відмовляєтесь від продовження терапії? Які ознаки є підставою для цього рішення.
Okay, so about the increasing of dosage, if it has to happen, it has to be discussed with the patient. What sense does it make for him? Keep in mind that the first psychedelic session or the first session with a new substance will have a decreased effect because the patient is very apprehensive of this novelty. So sometimes if you keep the same dosage on the second session, the effect is stronger because the patient know how to navigate and how to experience that. So yeah, that's very important. If you increase the session, do increase slowly because if you can, do not go too fast because there can be very traumatic psychedelic experience that are too strong can traumatize people again, especially people with PTSD. So be gentle about when to stop. On my decision, psychedelic therapies is about it never happened. It's about breach of boundaries, I think. If patient go out the session room, if patients have inappropriate behavior, especially in groups, violent or sexualized behavior, that's definitely something you want to address and something that should be a red flag for pursuing therapy. If a patient develop either manic or psychotic symptoms, obviously you don't want to give him more reason to experience those severe psychiatric symptoms, and you have to maybe change, especially if you work with a young population. Psychedelic can unveil severe psychiatric condition, bipolar disorder mainly, but also maybe schizophrenia. So that's a no-go. And yeah, that's it. Breach of confidence can also happen outside of the group. If, for example, you do group therapy and people obviously doing group therapy, it's normal for people at some point to meet outside of the group session. But if people have like using or selling drugs to other member of the group, that's a big breach of ethic for the group members. So this is something that should be addressed within the group with the exclusion of the voting member of the group. But this is also what happens in group therapy, I think.
Дякую.
Так, дякую. Є питання з чату від Максима Радіонова. Пане Максим, я тоді його зачитаю. Чи ви самі хочете включитися? Ну, поки пан Максим відповідає, в мене в продовження цього питання, є ще питання. От ви, пане Олександр, згадуєте про маніакальні і психотичні епізоди. І в мене питання, чи якимось чином, можливо, є інструменти, які ви використовуєте для попереднього діагностування і валідації людей, які схильні до психозів, так? Тут, мабуть, я додам, що західне суспільство, воно більш невротичного типу, здорового. В нас же наразі через війну і наш попередній досвід, більшість, це, знаєш, може бути узагальнене, але більше ми знаходимося в межовому і психотичному діапазоні. От, і мені здається, що це якби таке важливе питання, тому що з того, що я помічаю, що люди приходять на інтеграцію, людей після рекреаційного вживання психоделічних речовин чи десь підпільного андеграундного вживання, може розганяти в психотичний стан, психоз. І цей індукований психоз, він залишається з людини, і поступово розганяє. От. І, відповідно, вона може потім відлетіти в умовну феноменологію, втрати контакту з реальністю. І в мене питання стосовно перед початком роботи, можливо, ви з цим якось працюєте, діагностуєте, які інструменти? Дякую.
So first of all, to do a psychedelic session, the patient have to feel confident about the therapist, but the therapist has also to be confident about the patient he's going to accompany. What I do is do take your time to screen patient. Do not rush, even if the group, for example, start at some point. If you're not totally confident or like 90% confident that the patient will be stable enough to handle the group, do not rush things. Do also keep in mind that, yeah, the psychotic neurotic division, maybe with the traumatic events people suffer in Ukraine, the dissociative aspects are very high. But you're better placed than me to know. So do differentiate psychotic patients with severe dissociated patients, which are not the same. Because obviously, dissociated patients can look the same, but they don't. They can have hallucination. They can have, out of reality contact. But this is something that takes time, and do pace yourself. If you hesitate, if you have a doubt, do not expose yourself or the group to something doubtful. Take your time, wait a bit, meet the patient a few more sessions to see how he respond to classical treatment, how he respond to classical psychotherapy, and yeah, do not rush things, obviously, because that's when things can get sloppy.
Угу. Дякую. Пані Анастасія, і потім задам питання від Максима про радух.
Добрий вечір. Дякую за структуровану і насичену лекцію. І от хочу зрозуміти для себе. Ви кажете, що ми маємо поважати темп клієнта умовно. Якщо він на групі не хоче пред'являтись більше, ніж вирішує, не пушити його. Це про повагу до супротиву?
It's about the respect of the boundaries they can set within the group. Traumatized people have a lot of trouble putting and respecting their own boundaries. So obviously, if during the group session you go and don't respect those boundaries they're trying to erect, it's going to be the opposite of therapeutic. So sometimes it's very therapeutical for patients to just say, okay, I just don't want to share anything, and being respected into that is very important. It does not mean that you should not talk. Sometimes those patients, they allow themselves to talk more if you have individual integration session on the side, which is something you can always propose. So yeah, sometimes people prefer to stay silent and observe and think within themselves, or sometimes they just, I have a patient that was very silent for the whole 2-hour integration session, and even when we solicited him, he was staying silent, and then at the end he just had in 4 sentences the more compact, dense, intense quote of the whole session, summarizing everything that was sent during the session and that happened for him during the dosing session. So yeah, let them have their own pace.
Так, і я до того, що якщо в цьому ритмі суть або база – це супротив. Бо на кону ж зміна, трансформація, трансцендентний стан, щось подібне до смерті, умов. Я про цей саме момент. І тоді це як їсти слона по шматочкам, коли ми розкачуємо контейнер, тобто сесія до сесії, так якось.
I'm not sure I got the precision you wanted to make.
І я маю на увазі, що якщо цей опір є, ми ставимось до нього з повагою, то це пов'язано з тим, що недостатньо внутрішнього, наприклад, контейнеру, щоб обробити те, що є або має бути. Так? Ага. І тоді ми з кожною сесією, умовно, його можемо або звільняти, або розширювати.
Okay.
Це питання, так чи ні? Чи я не в ту сторону думаю?
To have more space. Yeah. Perhaps what is also very important is contrary to what has been sold on Mike and Pollan's book and every news outlet about psychedelic, is for severe suffering patients. It takes sometimes many psychedelic sessions to open up. I have one patient that was abused during her childhood that only for the first time, even though I was treating her classically for 3 years before, after the seventh session, she spoke about child sexual abuse for the first time. And yeah, she was not really. So sometimes it feels like you bump against the wall, you know, you're a gentle wall. They can bump as long as they need to before opening up. If that's an answer for you.
Дякую.
Do not feel frustrated if they don't feel safe. Sorry.
Мгм.
Так, дякую. В продовження питання якраз Анастасії та питання про, знаєте, яка пауза і між сесіями з психоделіками? На що ви орієнтуєтесь, коли вибираєте та одна сесія, потім наступна? На що ви орієнтуєтесь? Які, можливо, є мінімальні і які, і як робите вибір? Дякую.
Okay. For MDMA, as I said, there's this aspect of neurotoxicity. So you have to really space the session at least a month and a half. I go for 2-3 months. What other aspect is very important for the other psychedelic on a pure pharmacological aspect? You could repeat the dosing session every week, for example. But what is really necessary, because if you work in a psychotherapeutic paradigm, is to let people integrate between the session. Sometimes it takes a long time to integrate. I have, for example, a patient I worked with LSD who took over a year to integrate all the aspects of this experience. So do not rush too fast to the next experience as a therapist, because you want to give the fastest treatment for your patients. Have themselves go slowly. Do not go too fast with the patients that want to go too fast. Sometimes it's also avoidance, not to integrate the experience that was difficult. It can be very seductive to multiply the psychedelic experience, always looking for an answer in the next one. This has been called spiritual bypassing in the recent literature, but it's something known since Buddhists spoke of that for over 1,000 years. So yeah, do be aware of patients avoiding confronting and changing themselves by diving into the psychedelic world.
Ну так, справді, умовний spiritual bypass, він ну, виникає, і от я теж от зустрічаю те, що люди використання психоделіків, знаєте, використовують для цієї дисоціації. І тут виникає місце для такого психоемоційної залежності. І в мене питання так, стосовно цієї теми, так? Процес інтеграції, так? На що орієнтуєтесь, коли ми розуміємо, да, от коли ви розумієте, що інтеграція цього досвіду відбулася? Ну, от це все цей клієнт цей досвід умовно інтегрував, і є можливість розглядати наступну інтервенцію з психоделіками. А коли не інтегрував, теж.
Sometimes they just tell it themselves, after a session you do advise, take some time, listen to the music again. It can cue remembrance of the dosing session, journaling, takes up space, do not go to work, etc. And sometimes patients, go back to work straight after that. They pack their timetable with everything, social, work, they go to sleep, they don't have space to integrate. So this is one big cue that they do not, they are avoiding integration. Other than that, just ask them, Phil, how do you feel about the last session? Do you feel like you've been going through all the aspects? You want to talk? Ask them and try to feel how it goes. And yeah, I mean, psychedelics can be very confronting, obviously. So rushing for a patient working on difficulties, traumatic events, rushing to the next session can be a bit strange. Most of the time, patients are almost reluctant to go back to those spaces again. They want, to rest, to integrate, to prepare themselves. And once they feel ready to have this very sometimes harsh session, they tell you they're ready.
Дякую. А пане Вадим, від вас питання, і потім нарешті до Вердуга перейдемо.
Так, дякую. Олександре, скажіть, будь ласка, псилоцибінові гриби, вони є достатньо доступними. Як ви оцінюєте досвід їх самостійного використання? Наскільки це є ефективним з точки зору покращення самовідчуття пацієнтом? І друге питання, що саме додає психотерапевт, який використовує цей метод, щоб підвищити його ефективність? Яку ви ставите перед собою мету, коли працюєте з пацієнтом у цьому стані?
Okay. So about the first session, sometimes people use underground psilocybin. They cultivate themselves because it's very easy and very available. What I do advise for patient that comes to me for psychedelic therapy is, okay, let's focus. Okay, we know you can navigate psychedelic by yourself, but if you want to do psychedelic assisted therapy, let's only use psychedelics for a period of time in the psychotherapeutic setting. So you really focus your intention, how you live, how you experience. This is not always followed, but also this is something you have to discuss. And sorry, I forgot about the second aspect of the question.
Що саме додає психотерапевт, коли він використовує так.
Okay. Most of the patients that comes to me for psychedelic assisted therapy are patients that never use psychedelic on their own. I do think that a lot of young or adventurous person in Switzerland use them on their own or in other settings, for example, neo-shamanic settings, etc. People that I receive, I made the data a few months back. They tend to be around 40 to 50 years old. They have no use of past psychedelic or substance use. So they never experienced any form of altered state of consciousness, and they're very afraid of that. So I do offer medical academic setting with security in case anything goes bad, but things don't go bad most of the time. Also, if you are a sitter, a sober sitter present, it's very different than being on your own. And yeah, what I also offer is intervention. I do think that the therapists have an active role as an operator. The medical paradigm in the West tend to limit the psychedelic to only a pharmacological substance, whereas I think that a traditional use, like for example ayahuasca, have a very more performative stance during the session, which is what psychotherapy is also about. The neutrality of a psychotherapist is not, just being a blend, is being a blank slate of not projecting but reflecting back to the patient what he experienced, and this is something very proactive if you do it. What I also do during session is when patients are in difficulty, being present, getting closer to them, sometimes just putting my hand on their hand or venting them with a fan or using some perfume. You can testify your presence as a therapist and in many ways, and this is very grounding for the patient. Okay, we agreed that the first step, if I was looking distressed, is using the fan and just putting some fresh air on my face. I feel that my therapist is with me. It's okay. I can go to that place. The role of music also is very interesting because I use different playlists based on emotions during the session. So I try to feel and understand where the patient is. During the session, we talk a bit so I can, okay, let's now go to darker places and use, for example, musics that reminds you of your childhood, if that's want to work, and go to this place, then have some lighter, gentler music. This is also a very active and performative role, choosing the music and helping the patient with the music.
Дякую.
Так, дякую. Наскільки я зрозумів, музика тоді є інтервенцією для того, щоб підняти певний матеріал клієнта.
Yeah. Yeah, it can ease if I ask the patients to send me a few music tracks before the session, a few days before the session, so I can listen to them. Familiar music is a base of security or can be a cue for memories. And what is very interesting, because I'm a bit of a music geek, is I try to find cover songs or other version of the song they send me, especially without voices, and that helps because it makes them feel a bit unstable. I know this tune, but it's not the music I was expecting. So what's happening? And this is also sometimes unlock some processes. What I try to avoid but reintroduce at the end of the session is human voices, because obviously even voices in language you don't understand can be the vectors of emotions, intentions, and that restrain the scope of thing you can experience. So in my playlist, there are a few human voices I use, but it's more, very gentle, comforting songs when people are experiencing difficulties. It's also reminding of the use of Icaros in the ayahuasca setting, which is very important and can help people navigate throughout the experience. So that's very interesting too.
А вас просять, пане Олександре, поділитися улюбленим плейлістом, якщо це можливо, бо ви так згадали, що ви меломан. Може, через це.
Yeah, I can send what do you want? MDMA, LSD, it's not fixed playlist. Every playlist is made on the go for any patient. The only fixed playlist I work with are ketamine, because it's way shorter and it's a bit more, it goes really fast. So what do you want? I can share.
А якщо ви поділитесь з Іною, ми просто в продовження зустрічі зможемо потім викласти і поділитися зі спільнотою загалом, якщо ви не проти.
Yeah.
Питання з чату, так. Як впливає наявність РДУХ у пацієнта на вибір речовини чи схеми лікування? Чи, мабуть, можна
No.
навпаки задати, та? При РДУХ з якою речовиною працюєте, якщо, мабуть, працюєте, чи, можливо, можете на якісь дослідження, власний досвід посилатися?
Yeah. Okay. So, ADHD, very big pseudo epidemics in the Western world. I got back from a very intense pro Ritalin prescription stance to very different aspects. First of all, you should know that, every PTSD patient can have ADHD-like symptoms because of the hypervigilance. So don't rush to treat ADHD. Do think, is it something else, first of all? MDMA is very interesting because since it's based on an amphetamine, it's met-desoxymethamphetamine, the full name, MDMA. Patients with ADHD or ADHD-like disorders feel way more calm when under the influence of MDMA, which is really interesting because then you can work, okay, this difficult to focus, this distractibility, sorry, I'm a bit tired. This distractibility does come from a difficulty to face something inwards. So what happens when you're calmer, you're more connected to yourself? What do you meet from yourself? For if I can say so, this is very interesting, and also people with ADHD sometimes they feel like they need to overperform because of cognitive rigidity about what is being perfect and etc. And you work on that, how to be vulnerable, how to be, being able to be wrong sometimes, etc. And it decrease the need to overperform. So sometimes the distress from being distractible is much more manageable. And so when you work around trauma, you help people with ADHD-like. When you also treat other, for example, avoidant traits that were not diagnosed before, you also work on distractibility and difficulty to focus. So yeah, ADHD is a strange beast.
Угу. Так, дякую. Ще питання є про, зараз я його перекладу. HPPD – це стійкий галюциногенний розлад сприйняття, так? Як тоді питання, як його перекласти наступне, як часто зустрічаєтесь ви з стійким галюциногенним розладом сприйняття, англійською це hallucinogenic persistent perception disorder, та і як з ним працюєте? Дякую.
Okay, so I don't have had any patient that had HPPD, sorry, during my therapeutic session because the risk factors for this severe adverse effect of psychedelic use is there are first, the age of use. Younger people have a less, the theory is that younger people have a less mature visual cortex, still pruning up until the age of 20. So that can increase the risk of HPPD. Second, you have the question of the high dose, which increase that. I work more in psycholytic, and the whole Western world works in like the. Recently, there was a study about high dose LSD, which was only 200 micrograms, which for people in the 60s was like medium standard dose. So there's a bit less. And also the setting plays a lot. If people have traumatic psychedelic experience, there's a higher risk of having HPPD. If that happens, obviously you can use anxiolytic, you can work on integration a lot and do accompany those patients because it's very distressful. It does decrease slowly over the course of 1-2 years, if I remember correctly. So you have to accompany themselves during that. Uh, yeah. But if you prepare your patient,
Угу.
if you dose not too much, and if you have a secure setting with patients that are not teenagers, you decrease the risk. It's basically close to zero.
Цікаво. У мене є припущення, що тоді цей HPPD може бути пов'язаний з спектром РДУХ, якщо це стосується префронтальної частини, ну, кори головного мозку.
Mhm.
От, у нас вже майже 2 години, будемо завершувати поступово. Хотів іще задати питання. Повертаючись до роботи з псилоцибіном, я бачу, що ви згадуєте і вказуєте на те, що ви працюєте в Швейцарії безпосередньо з синтезованою молекулою псилоцибіна, так? Ви не згадували про різні види псилоцибінових грибів, тому я тут трошки межувався чи питати, але цікаво, можливо, ви це питання якось досліджували про роботу з різними видами псилоцибінових грибів і їх вплив. Тому що так суб'єктивного досвіду, так емпіричного досвіду, це воно трохи це все псилоцибіновий досвід, але воно по-різному може відбуватися в динаміці.
Yeah. Yeah, it's very interesting. Pharmacologists tend to think that the effect of the psychedelic is only linked with one psychoactive compound in the aspect. Is for psilocybe mushroom, it's psilocybin. For ayahuasca, they only speak about DMT. And obviously, it's very reductive thinking that other compounds have psychoactive effects. They changed that. I think in the recent year they realized that different strains of mushrooms have different proportions of psychoactive compounds, not as active as psilocybin, but still quite active. So this is why you have testimony of people being able to differentiate different strain of mushroom. I do hope that in Switzerland, some point in the future, we will be able to work with psilocybe mushroom extract, natural, with the other compounds instead of pure synthesized psilocybin. But for now, if I want to stay above ground, legal in my practice, I can only buy my synthetic psilocybin from one producer, and that's it. So yeah, that's the limit.
Угу. Так, дякую. Колеги, можливо, є ще якесь завершувальне питання чи побажання, пропозиція? Ну, мабуть, що вже і так було насичено і достатньо. Хотілося ще поговорити з вами про феноменологію досвіду, так і його онтологію, про образність, про як працювати з різними рівнями образності в інтеграції. Тут я маю на увазі, коли людина сприймає якийсь образ, форму, сутність, like entities, так, і як з цим працювати, так, які підходи, так, але я гадаю, що це вже буде така розширена тема, яка вже для наступних зустрічей. Так що я всім дякую. Дякую, пане Олександре. І, можливо, якесь наостанок вам ваше побажання чи настанова для нашої спільноти.
Yeah, as I told Ina, I'm always open to question. On the slide I will send you that are in English, there's my email address. So if you have any question, do ask them to me. I'll try to translate Ukrainian to French and respond back with AI translation. But yeah, yeah, I'm really open to discuss. I also propose to accompany for group supervision if you need those. So yeah, it was really nice and really important for me to share this experience with you. So thank you for having me during your cycle of conference.
І вам вдячний особисто і від спільноти. Дякую вам і тоді до наступних зустрічей.
Thank you.